Hello everyone. In this video, we're going to dig a little deeper into the dynamics between patients and providers and their health communication. In particular, we want to look at some of the unique aspects of each perspective. So if we're talking about improving health communication, we're usually talking about improving empathy between the interlocutors, which is a fancy way of saying the people who are talking to each other. And so in order to do that, we should consider some of these unique pressures that they have. Patients and providers both have unique perspectives and pressures, factors that are influencing their interactions. However, these pressures and whatever other factors that are kind of unique to these situations, well, they're not so unique that they don't have something in common, and they do apply to us all in different contexts as they arise. So by exploring these a little bit deeper, we're going to get into some important issues, not just for patient-provider communication and health communication in general, but also you might learn something a little bit about yourself and how these kinds of pressures manifest similarly in your own life. So with the patient side of things, I've made this lecture mostly investigating identity issues and how health influences our sense of self. And from the provider side of things, we're going to dig into a lot of how stress and burnout can impact people in the workplace and how that is a particular threat to healthcare workers. Perhaps it's best to begin by discussing what the textbook refers to, and this is coming from a very old book called The Discourse of Medicine, but what the textbook refers to as these two different voices, the voice of the life world and the voice of medicine. And so the idea here is that patients tend to use the voice of the life world, whereas doctors will often use the voice of medicine. Now, despite these names being kind of weirdly philosophical, what they're talking about are two different frameworks that people are using when they encounter these interactions, when they enter these interactions. So the voice of the life world is characterized by a lot of discussion of feelings and thinking about context, and it's more comfort seeking and emotionally expressive compared to the voice of medicine, which is a little more evidence-based, measurement-based, treatment seeking, and emotionally controlled or restrained. Precise and diffuse are words that the textbook brings up when discussing these two different perspectives in terms of the voice of medicine is going to be very precise in terms of I want to find out what's wrong with this patient so that I can fix it, right? Identify the problem precisely and make a precise intervention that can help them feel better. Whereas a patient is going to tend to enter these interactions thinking about how their health impacts them in a lot of other ways. How does it impact their day-to-day life? How does it impact their family? How does it impact their ability to sleep? How does it impact other aspects of their life? How much does it hurt to get out of bed in the morning, right? That's a little more diffuse. And so those terms can help us understand already some of the ways in which patients and providers might be coming from two different directions, but they might also be on like two different roads, right? So we have to work to bridge that gap if we want to improve health communication. And there's a lot of ways in which doctors work on this. And so, a lot of things that we as patients or doctors someday can do on the other end. So um, think about how you conceptualize health. What do you think of your own health? Now, for your personal health, I mean, if we really want to draw a distinction between these two voices, think about your own health versus someone else's health. If someone's telling you about a health problem, you might be concerned about, well, how should we fix that problem? And you won't necessarily be immediately concerned with how it impacts their life, depending on who you're dealing with. But if you're talking to about your own health, then you're going to think about it more in the voice of the life world. And probably likewise, if you're talking to a loved one, and they're having health problems, you're going to think about it more in the life world. So one's a little more subjective, one's a little more objective. Now, when it comes to providers, the dilemma that they face, I think, stems from this dilemma of experts in general, in that they are specialists, they are experts, they have achieved a very high level of education in order to provide expert care, right? Expert knowledge for expert care and that kind of precise treatment. However, that means that they think and speak in a specialized language. And so when one becomes an expert, they have to work hard to translate things back to other people who don't have that same level of expertise. That is an ongoing dilemma for scientists, health experts, and pretty much anyone who's an expert of any kind, right? Patients think of health in terms of how it relates to their own life experience, probably more so than in terms of technicalities. Um, it's just the way it is. And you could take this to any domain of life, even like sports. If you're an athlete in a particular sport, you're probably going to have a much better understanding of the vocabulary of that sport and what's going on there than I would have because I don't follow as much by way of sports. But you get the idea here. So I want you to consider for yourself, you can take a moment to think about this or think about it as we go along here, but what kind of dilemmas, or what the textbook was referring to, kind of a dualistic uh, situation, the dualism and transgressions can we expect to arise as a result of these, ships passing in the night kind of situation? What kind of conflicts can emerge? What kind of difference of intentions can occur? What kind of different goals are these different parties going to have, right? So keep that in mind as we go throughout the rest of this lecture. Now, starting with the patient side of things, as I mentioned earlier here, I want to focus a lot on identity and how that functions in terms of how we get tied up in our health. It's another important part of our aspect in ourself, and that we carry that into the interaction. So when we're talking about identity, in particular patient identity here, um, we're asking ourselves these questions of who we are, how do we know that, and how do we maintain that image of ourselves? Well, the word used to describe this is face work. In cultural communication, this is discussed a lot because different cultures have different priorities when it comes to maintaining face, as it were. But this idea of saving face is an old one, and it has to do with our publicly presented self, or privately, but our presented self, right? And in interactions. So face work has to do with the self that we present to others, and it takes a lot of work to maintain our identity. It's not, we may think of ourselves as simply being. However, as social animals and having social identities, there's a lot of work that goes into interacting with other human beings and presenting the version of ourselves that we think is most appropriate for the given situation to those people. We refer to this as face work in communication. It's a communication process, right? Because you're interacting with someone else. And we want to think about now, how does this process change when people treat us differently than they used to, for instance, right? And so here's this little table is just kind of laying out some different ways of thinking of our identity. We have our personal identity, which is my concept of self. Who am I? How do I define myself? Well, maybe this was easier to do when I was younger. Maybe it's gotten a little harder. Maybe it's easier in some ways and harder in others. But, we have a concept of who we are based on just being ourselves. We also have a social identity, which is related to our perceived and real group membership. So without going down that rabbit hole too far, we can, in diversity studies, there's ascribed identity and avowed identity. And avowed identity is, again, this is who I define myself as, perhaps in relation to my social group, and like this is how we define ourselves. Um, or ethnic group. Social identity can extend out of ethnicity. They're not exactly the same, but often people's social identity is tied up in their ethnicity. Um, but society is also going to look at you and ascribe an identity onto you, right? How does society define you? I'm not saying anything, this is good or bad or anything. There are good and bad aspects of this, but it is a part of our identity, right? We exist as social animals in a social world, or a society, and there are consequences to that. And so that's what we're talking about here. Now, this idea of a tertiary identity has to do with, or a third identity, has to do with our health and how our identity is modified by our health status. So if you have an illness, how might you be defined by and in relation to that illness? We can discuss this in terms of a chronic health condition. We can talk about this in terms of a positive COVID test, right? How does that make you feel in terms of how you view yourself and how society views you at that point? We could talk about this in relation to the normal trajectory of life, right? In terms of major life changes or just getting older. As we age, things happen to our body that it's just the way it is, right? It's a natural progression, but it does change how we view ourselves. Most people don't really tend to think of themselves all that differently past their 30s, but we continue to get older. And so what does that do to our identity as well? This all falls into the category of kind of a tertiary identity. Now, a textbook is most interested in this using kind of the example of chronic health conditions. I myself have a chronic health condition. I've been diagnosed with psoriatic arthritis. I'm okay with disclosing that to you. I'm not particularly sensitive about it, but it might serve as a useful example here. This theory that the textbook introduces is called Managed Meanings of Embodied Experiences, or MMEE, and it has to do with the idea that health is interwoven with ideas of being, doing, and directed becoming, as the textbook says. So this is coming directly out of the study, and these each have fairly specific definitions, but you can use your imagination here. The ideas of being, of who am I, right? Our sense of self, doing the things that we are able to do and have always been able to do, and directed becoming being the things that are now going to be changed or modified because of our health condition. So this theory, all we really need to know about this here is that it's talking about stages of identity negotiation. Now, I think this is interesting, and we can compare it to other stage-like theories that you may recall if you've ever learned about the stages of grieving or culture shock, for instance. It's a very similar pattern. All of these, they're major life changes, and whenever we go through a major life change, we go through stages. It's not a clean transition unless you have cultivated a specific behavior in relation to going across cultural boundaries, for instance, in the instance of culture shock. But you'll still experience culture shock even if you have. Now, or the stages of grief, right? There's anger and resentment and negotiation and then acceptance. Like things don't happen immediately because we are resistant to change. But same thing here, right? Our identity is forced to be renegotiated as we are faced with a new situation or a new health situation. So the first stage of this one would be the supernormal identity stage, right? You're going to be extra focused on who you are, who you were, what you could once do. All right, this isn't going to slow me down kind of thing. I'm still going to do my marathons. I'm still going to do whatever. In my case, when I was diagnosed with psoriatic arthritis, it was I think 2018, and I've always been fairly active in terms of swimming and things like that, and I can still do that even with psoriatic arthritis. But it was surprising to me that I was going to have to be on a medication for the rest of my life, and that distressed me, right? That shook my sense of self, and I was like, well, it's not that big a deal. It's just I'm going to be able to do everything that I've ever been able to do. It's not going to slow me down. Fine, right? Okay, I've got some little arthritis, but I can still exercise. That's one of the benefits of psoriatic arthritis. There's a benefit, but on the plus side, exercise generally helps as long as it's low impact. Now, the restored self, when you try to do the things that you used to do, you are forced to recognize that, well, I'm still me, but something ain't right. It hurts a little bit more to get out of bed every morning, but in 10 minutes I'm back to myself typically. Right? That's the sense of restored self. I'm being forced to confront the fact that I can't do all the things I used to do, but I'm still myself, right? I'm not that different. The third stage of the contingent personal identity, this is where you really start facing your own limitations. So there are a lot of things that I will not be able to do anymore. I went through pilot training when I was younger, and you have to get a flight medical in order to have an active pilot's license. So I will never be able to pass for instance, a class 1 medical exam. I'm not sure I could ever get a commercial pilot license anymore because I have been diagnosed with psoriatic arthritis. That's not the only thing. I can't really do heavy weightlifting. I can't do high impact stuff. I'm not supposed to run a whole lot. I can still swim, thank goodness. But there's a lot of things I can't do anymore. And that's really depressing when you get to that point of a chronic illness or something you're going to have to live with the rest of your life, where you're faced with this idea of I may not be able to do everything I used to do. I can't just jump into a pickup game of softball. Can't do that anymore. Some of that is with aging as well. Once you get in your 30s, you probably can't do much of that anyway. But uh, that's hard when you are forced to recognize that you can't do all the things that you used to do. And again, this happens to people as they age as well. It doesn't have to be a chronic health condition. Age is a chronic health condition too, right? Um, but ultimately, you end up with what they refer to in this theory as a salvage self, right? It integrates former aspects of yourself with your new limitations, right? No, you cannot do everything that you used to do when you have a chronic health condition, or as you get older, again, or if you have children, if whether you're a man or a woman, if you have given childbirth or are just have children in general, that's a major life change as well. But childbirth is a traumatic experience on one's body. Right? There are a lot of physiological changes. A lot of things change that will never go back. And sometimes you just need a doctor to say, hey, it's okay, this is normal. But you do need to renegotiate that. Every time you go through a major change in your health or life, you're going to go through these stages, right? But ultimately, I guess the point of the theory is to recognize that we do get to a point of comfort, or some relative comfort or peace, um, or at least that should be your goal, right? Not to do all the things that you used to do. You're never going to be able to do that. However, you can get to this point where the parts of you that truly matter are still intact, and then you renegotiate your new existence with who you are. And that's the idea here in terms of the tertiary identity. There are more healthy and less healthy ways to arrive at that point, but hopefully people can get there. The idea here, though, is recognizing that health and identity are not separate things. Sometimes a doctor may forget this, but as a patient, you are very acutely aware of this. I'll give you one last example. When I have to do injections every so often, right? And when I had to do the first one, I can remember it was very, very stressful for me. Not because I was scared of needles, but like my hands were shaking and everything. What was scary about it was the recognition that as soon as I started doing that, there was no going back, right? It was admitting to myself that, yes, I have to deal with this now. It's not like a bacterial infection that I can take antibiotics and make it go away. This is going to be a permanent aspect of my life. And that was a very hard thing for me to deal with. I'm doing okay, obviously. I'm living my life just fine, and that's what you got to do. But some doctors may not recognize that when they walk into that room and they say, oh, yeah, you've got arthritis, and that's just going to be that way. Whoa, that affects people because it impacts how they view themselves. Now, there are a variety of communication skills that can help people deal with these kinds of situations and that can help doctors help patients in these situations. So these tips apply whether you are a family member offering social support or whether you are a healthcare provider in the future or just a stranger stuck on the subway listening to someone talk about their chronic health condition. One skill is listening. Go figure. Remember that stories are part of how we define and maintain our identity. Earlier, we talked about the role of narratives in patient-provider interactions and how doctors may not feel like they have time to listen to stories, and they may not be super patient for that. But if they do listen to the narrative aspect of the patient side of things, they may find things that they would have missed otherwise. Look below the surface. If you know someone, a loved one, or someone else that has gone through either a traumatic event or had a major health change, diagnosis, something along these lines, people have different reactions, and well, that's the next point, right? People are going to have varied reactions to that kind of thing, and if someone is taking it well, so to speak, that might be more of a mask that they're putting on, and it doesn't indicate that they don't need social support still. Taking it well might mean being a little unrealistic or hiding deeper emotions. If someone is like, this isn't, if they're in that first stage and like, this isn't going to slow me down, and they go out and try and run a marathon and injure themselves, well, that would be a problem, right? And so, as if we are trying to help people in this situation, then it might be an opportunity to engage with people a little bit a little bit lower. Again, it's hard to predict how people will react. Everyone's going to react differently to these kinds of situations. And so as we are interacting with someone in a communication situation, interaction with someone in this position, it's important to honor the importance of multiple perspectives. For instance, the fact that they're not going to be able to do everything that they used to, but acknowledging that who they are is still there, right? Not devastated, not shook, right? We want to reaffirm that identity in some ways. Recognizing that treatment goals and identity goals don't often align. I don't really think of myself as someone that has to get an injection every so often, but we have to renegotiate those things, right? It demands a little bit of flexibility and a lot of honesty. So these skills can help if you're in a social support situation. It can also help us recognize if we are diagnosed with something that we would rather not be diagnosed with. There's a lot that we can do to improve that situation. Social support is very helpful for that. A little bit of conversation, communication, empathy goes a long way. Now, on that note, we want to be careful what words we use. Obviously, words like survivors versus victims have very different connotations, and they can have unintended consequences. You never know what's going to set someone off. People can become very sensitive to those things, and even surprise themselves in terms of what kind of emotional response they might have to a given stimulus. So, do you need to be the word police and be super, super sensitive to every single word you say? No, that's not what I'm saying. What I'm suggesting is that you recognize that there are important clues in conversations in terms of how people refer to themselves. And that might be an opportunity for a dialogue, right? If someone is referring to themselves with kind of a derisive tone or term, then, well, maybe that's an opportunity to talk about it and see what's really bothering them. All right. So that's kind of the major premises of the identity stuff that I wanted to get into. Now I'd like to switch the conversation over to looking at providers and their unique perspectives. This is more on the chapter 5 side of things. And I like that this chapter is pointing out some of the unique challenges that providers do face, because they face a lot of unique challenges. And healthcare professionals may often fall into the category of what we call in communication non-entity status or non-person status. If you want to know what that looks like, work as a bartender and see how quickly people act like you're just part of the furniture. The conversations people used to have right in front of me when I was a bartender is incredible. That's kind of part of the job, right? But we want to if we want to improve communication, we need to be able to recognize the other party as a person, and sometimes that doesn't happen. So let's humanize providers a little bit and recognize some of the unique challenges they face. So I'd like you to ask yourself, what kind of things does a doctor have to go through to become a doctor, right? Think about the differences you perceive between yourself and your healthcare providers, right? Uh, Maybe they're totally different from you in your mind, or maybe you don't even think about it. Maybe you think of them as kind of robots. But at the end of the day, these are people a lot like you who decided to go into a healthcare career for one reason or another. And they are subject to the same identity conflicts and crises that we are, and they are still human. They have biases and other things. So think about now, the textbook has this interesting discussion engaging with difference the different challenges and obstacles that a doctor has to go through. So for one thing, when you go through medical school, there's a lot of isolation and unusual hours. A lack of sleep is a very dangerous thing, and it can really stress you out, especially if you're not used to that. And so we're not just talking about working the night shift. Some people that work the night shift, they get used to that. Their circadian rhythm adjusts, things like that. But if you are not if you work the day shift one day and then you work the night shift the next day, that's going to be very hard on you, right? Strict hierarchy, as with any organization, there is hierarchy, and in that hierarchy, there is going to be bullying, there's going to be hazing, there's going to be things like that. Thus, the expression here that the textbook reminds us of nurses eat their young, right? In the sense that someone coming up through med school if you're low on that hierarchy, you're going to get punished for it until you are not low on that hierarchy anymore. And bullies kind of beget bullies. Bullies were bullied often as they grew up, and it's a power thing. And so these things tend to reinforce themselves as well. But additionally, there's the positive aspects of going through something like medical school, such as the privileges and the crazy experiences, the good things that you see, the bad things that you see, the amazing skills, the amazing things that doctors are able to do, and they help people and they have this expert knowledge. But that can kind of create this disconnect between doctors and their patients as well by creating either a superiority complex or something like that. But think about that. If, for example, as in the textbook example, it says, right, this individual went to med school and having never even seen a dead person before, and then by lunchtime they were already part of someone's death. Now imagine how that starts to shape you over time as you're exposed to that kind of situation that you were never even exposed to before. And I want you to ask yourself, if you went through stuff like that, do you think you would feel more empathy or more resentment? Maybe probably a combination of both. But how do those experiences shape people's identity? It's hard to say, but it is interesting to think about, and we want to keep that in mind as we are considering the unique challenges that doctors face. There are a lot of barriers that they have to overcome that get them into that position, and it may not make it easier for them to relate to average people. So think about what it would be like for you to experience those things. Like you specifically, even if you have no intention of ever going into medical school. A lot of people went into medical school who are a lot like you, right? How would you feel? How would you react to those situations? And how long would it take for you to burn out? And then what do you do? Well, let's explore some of that a little bit deeper. So I've got the rest of this kind of organized into our micro and meso and macro factors. Let's see if we can explore those a little bit. Mostly with the micro and meso stuff, I'm talking about individual and organizational level factors such as patient-provider interactions and things along those lines. So we're going to talk about all of these. We've got psychological factors on the individual level. We have stress and burnout. Those are individual experiences, but they contribute to an overall climate and culture in the organization. We have medical mistakes. That's probably a little bit more meso. And we also have the interprofessional teamwork side of things, which is kind of a solution to some of these problems, but it has its own drawbacks as well. Now, when discussing these psychological factors, there are several things that we want to get into, but the main goal here is to recognize that providers are human too, and emotion is part of the job. Not only part of the job, it is the job to a large extent. Healthcare is classified as emotional labor in a lot of ways by organizational communication scholars. And that's because most people who get into healthcare are doing it to help people, right? And they tend to be fairly empathic individuals. And when you're dealing with people who are in crisis, having health issues, well, emotion is going to be part of that. But doctors may not always think about that before they get into the job. Now, another aspect of this is we want to recognize that everyone has their biases, and biases are unavoidable. In this instance, we're talking about biases the provider may carry into the interaction or discover while they're there. This could be anything from your typical biases and stereotypes that people tend to harbor, but it could also be as simple as is the doctor, do they find their patient sexually attractive? Are they distracted? Do they think that they're an idiot? Did the patient reveal their political affiliation? And that now the doctor is like, whoa, I don't want to help this person because they're a Democrat or a Republican or whatever. When it comes to bias training and all the workshops and all that stuff, often they miss the punchline, which is to recognize that everyone does have biases. And so the goal there isn't to shame people for having biases, it's to recognize that, again, we are all human and we have our limitations. And by recognizing those limitations, that can increase our level of empathy for ourselves and others. and create more realistic expectations. I think that's the part that they don't always mention in the bias workshop. The goal is not to eliminate biases, it's to recognize them so that we can have more realistic expectations about each other. Now, in addition to that, even though emotion is part of the job, emotional responses either on part of the patient or the doctor can surprise doctors and take them off guard, right? They might have this very voice of medicine approach to things and therefore be a little surprised when someone is emotional or starts crying or angry or upset. They may be surprised if they start feeling emotions. Now, there are some healthy strategies that we can talk about and other factors in the work environment that can help providers deal with emotions. Not dealing with emotions contributes to burnout. And so we do need to address this kind of situation. Again, emotional labor is part of the job, and managing emotions isn't as simple as ignoring them. Unfortunately for some people, unfortunately for others, right? We might be tempted to just be like, all right, well, just don't get emotional, don't get attached. It's like, well, it's never quite that simple. We have to deal with our emotions, otherwise we get into trouble, and that can lead to burnout, which is what we'll spend the most time talking about in the remainder of this lecture. So things that do help are mindfulness. Um, Again, we can talk about this like a yoga retreat, or we can just talk about it in terms of mindfulness generally means cultivating awareness of how you are feeling, how others are feeling, and that can be useful, right? So recognizing patients' feelings, exploring what they're feeling by actively listening and encouraging them to describe those things, and then therapeutic action, inviting collaboration from those other individuals. These can all be useful ways to address emotion as it comes up in a patient-provider interaction if you're the provider. Now, if you're never going to be a provider, don't worry about it. We can still learn a lot by figuring out what helps in the interaction. It can help us acknowledge our own emotions, and we can do these things too, pursue those actions even if the doctor won't. Now, other things that help in communication is a little bit of confidence. Providers feel defensive if they don't have all the answers, and that might get them to shut down a little bit. We don't usually want our doctors to shut down. We want them to be engaged in the interaction. They might seem a little detached or cold in this situation. That could be problematic. So it helps to have a little confidence, and there are some things that can help us cultivate confidence if we're a provider, things that you can do as a patient to encourage confidence on your end. Satisfaction. Dissatisfaction is associated with stress and burnout in jobs and in life in general. More satisfaction is achieved for doctors when patients are friendly and forthcoming about their needs, and when providers are confident in their communication skills, that helps with satisfaction as well, and also when providers feel proud of their work. As we're going to see when we get into the stress and burnout side of things, there are a lot of factors that contribute to stress and burnout. One of those things is dissatisfaction. So feeling under-rewarded in your work is a big red flag that can contribute to that. But these are just some general tips, and you're going to see all the other strategies we talk about are going to kind of socket into these things. They're going to be related to these different factors that can help along the way. Next, I'd like to talk about burnout and stress. This is a major risk factor for people in the healthcare profession. It's a risk factor for a lot of people under chronic stress of any kind, but let's get into this a little bit. Why it's a particular risk for people in the healthcare profession is not just the amount of work that they're having to go through, but there is this recognition that the same qualities that make for responsive communicators make one more susceptible to burnout. So likewise, in the healthcare profession, most people are in there because they're fairly empathic to begin with and they care about people. So that also makes people more susceptible to emotional burnout. Now, what is burnout? Burnout is characterized by three interrelated dimensions. The first one being emotional exhaustion. Well, that's fairly straightforward. People get worn out, they lose patience, and they get too tired to deal with things anymore. Next, the other dimension is lack of personal accomplishment. This is pretty common among early career professionals and specialists, such as like an imposter syndrome kind of thing, where very common among grad students, where they think, well, what am I doing here? I don't really deserve this. Or, or if you're a medical student, who am I to be taking care of these people? I'm not good enough for that kind of thing. So that would be the lack of personal accomplishment, but that can also be a result of unsatisfying work. So it doesn't just have to be a ton of work or really hard work. It can be a lot of unsatisfying work that gives you no reward whatsoever. The depersonalization is the other dimension here that is usually measured. That is talking about a state in which the individual is losing their regard for other people. They start to dissociate a little bit. They either say something along these lines, or these patients are all idiots, or all my coworkers are idiots, or no one can do this except me. The kind of dehumanizing aspect of it, this is depersonalization. So these three interrelated dimensions are what are usually used to measure burnout. Now, what kind of things lead to burnout? There's a lot of factors, many of which I've already mentioned. One is workload, but again, we want to distinguish that we're not just talking about a quantitative workload, we're talking about qualitative workload as well. So a ton of work, yeah, that doesn't help, but also a ton of really boring, monotonous work, sitting on an assembly line doing the same screw tightening routine over and over again, that's not going to help you either. You can imagine with doctors, they have a little bit of both. There's a lot of paperwork, and there's a lot of hard work, and there's just a lot of work. And so all of this contributes to greater burnout. Role conflict is another one. The textbook raises this question of double binds, which is a damned if you do, damned if you don't kind of situation. Well, that would be falling under the category of role conflict. If you want an example of this, I have been very active about questioning the nurses I've been interacting with over the course of the pandemic in terms of their opinions. And usually I get varied responses. And I remember talking to one nurse, and I kind of sensed that she was not wild about the whole mandated vaccine thing. And I asked her, well, how did the other nurses feel? She's like, it's about 50-50, but it's really hard to tell because no one talks about it. Yeah. That's neither here nor there, other than imagine if you were a nurse in that situation directed to give someone a vaccine that you do not agree with. That would be the definition of a double bind, which is going to disrupt your perceived role in that organization. It's going to cause a cognitive dissonance. It's going to stress you out quite a bit. These are other common factors that lead to burnout. So role ambiguity is another one. If someone is like taking over parts of your job, that can be annoying. That can contribute to this as well. Intense emotions, and also the role of detached concern as a physician, right? You want to be empathetic, but not too attached, right? And there are a lot of intense emotions going through all these different situations in healthcare. So that's another one too. Outside factors, of course. You could have major life events. They could be good or bad. Birth of a child, very joyous occasion, very exhausting. Weddings, death of a loved one, all of that stuff contributes to this. And work-life balance. Different cultures handle the work-life balance differently. In ours, we do try to maintain a separation of work-life balance, but this gets more difficult as you're working weirder hours, if you're on call, things like that can really contribute to that as well. So those are some of the things that contribute to burnout. What does it do to people? Well, physiologically speaking, if you are in a state of burnout, as measured by the combination of those three interrelated dimensions, you are more likely to suffer from heart disease and high blood pressure. So there are some cardiovascular risks. These are the same general risks that are associated with stress in general. Chronic stress is not great for you. There are also attitudinal outcomes of burnout, such as lower job satisfaction and commitment to that job. And from an organizational standpoint, that's a problem because you have higher turnover, people quitting, people moving on, and you got more jobs to fill. But these are just some of the outcomes of burnout. For the individual, the health issues are not the only one. Obviously, the psychological effects are a problem, and they build on themselves. It's a recursive relationship between, for instance, physiological distress and mental distress. And those things can aggravate and build and become a bigger problem over time. So it's important to deal with burnout as it arises. Or, here's even better, stop it from happening. So now, luckily, if you are an empathic individual or have a lot of empathy, that can be beneficial in terms of dealing with burnout, but it can also contribute to it. So it's important to distinguish between what we refer to as emotional contagion, which would be feeling bad with someone, for instance. If you've ever been in a group of people, someone's in a bad mood, and then everyone's kind of in a bad mood, and you don't really know why. Well, if you don't know why you're in a bad mood, that might be a sign that you're experiencing emotional contagion. We would prefer that you have a regular old empathic concern, which would be a feeling for rather than a feeling with. That would be a good thing. So if you find that you have a friend who's stressed out and you are able to understand that, that's probably going to be more of a good sign of being empathic concern as opposed to the emotional contagion where it's just like, man, I'm in a bad mood now. Why am I in a bad mood? Well, the empathizing with people can certainly help, and communicative responsiveness helps as well. So more communicative responsiveness means less burnout and more commitment to, for instance, our occupations. That means having good positive relationships, listening, paying attention, and having a mutual conversation about a problem. That can help. It doesn't usually work when people try to do protective buffering, keep the emotions inside, not talk about what's bothering them. It doesn't make the problem go away, sadly, and it can contribute to greater burnout and stress over time. Some other healthy strategies that the textbook recommends for healthcare providers in particular would be such as having a daily debriefing with yourself. And now connect this back to our earlier discussion of mindfulness, right? This may be as simple as just asking yourself, what did I feel today and what made me feel that? That can be more productive than just kind of stewing along on your bad emotions. Be mindful of the things that make you happy as well. What things did you do in the day that made you happy? You want to take the time to think about that as well. Invest in gratifying relationships. If you spend time with someone and they make you feel worse, maybe you should spend less time with that person. If you spend time with someone and they make you feel better, that can be very helpful in terms of dealing with the consequences of stress and burnout. They also recommend designing your own time pie, as it were. Just managing your schedule is important. We can leave it at that. Spend time with people that replenish you. Same idea here. Invest in gratifying relationships. I don't think any of that's particularly profound, but you can take something away from it anyway, and just remember that a little bit of mindfulness and empathy goes a long way in terms of dealing with the things that lead to burnout and stress. Now, the next part we're going to talk about here is the role of medical mistakes. I don't want to spend a ton of time on this. The textbook goes into plenty of detail, but as it is related to what we're talking about, let's get a little bit of that in here. Burnout can increase the occurrence of medical errors. And so when we say medical mistakes, we can use the textbook's example of the guy who got the wrong leg amputated. That's a problem. We wouldn't like that to happen to us. What usually contributes to medical errors is a breakdown of communication. And so things like teamwork and not being stressed out can help with that. But in this particular example, it's not exactly just as simple as the doctor being lackadaisical or distracted or something like that. There were multiple steps in that process that led to them ultimately amputating the wrong leg. Now, the textbook is also very kind to point out for us that this wasn't quite as egregious a mistake as it seems. It's not like the doctor went in there and just cut off a good leg, right? The person that was getting his leg amputated, both of his legs were already gangrenous from severe advanced diabetes. And so they were going to cut off both legs eventually anyway, but he wanted the right leg cut off first because it was causing him more pain. So, honest mistake, maybe, but like a surgeon should still be double checking the chart to make sure that they're cutting off the right leg. He took off the left leg because it was in worse shape, but also because there was a breakdown in the chain of command where a nurse had noted the wrong leg and someone hadn't double checked it. If you've ever been in for surgery, you know every single nurse and surgeon who comes into that room asks you, hey, what hand are we operating on today? And you show them your hand and they sign it with a permanent marker and put their initials there. And like 5 people do that to make sure that they don't operate on the wrong hand, right? There's a lot of things that go into successful medical intervention and a lot of things that can break down. The more complex that system gets, the higher the risk for medical mistakes becomes. Some are avoidable, some aren't. And now, what the textbook is most concerned about is that the recommendations for providers who find themselves in a situation where they have made a medical mistake and how to deal with it. Now, usually the same things that help with good communication to begin with are going to help here. A little honesty, empathy, and responsiveness. It doesn't help if the doctor is like, oh, no, you'll be fine. Don't worry about it, right? That doesn't really help so much. So it's important for doctors to be as honest as they can be and to own up to their mistakes. And usually that's enough for people who have been on the receiving end of a medical mistake. Often in research and surveys, people who've been the victims of medical mistake mostly just want the doctor to own up to it. They just want an apology a lot of the time. And exercising these good communication skills can get doctors out of a few more lawsuits. Now, with all of this stuff, the textbook is kind of building up to the idea of interprofessional teamwork as a solution to some of these problems. It's in some ways it's a solution, in other ways it's not, but it does help in terms of a lot of the medical mistakes are a result of communication breakdown, and stress and burnout is another consequence of poor coordination and poor support networks at the workplace. Now, it does help that there's a greater emphasis on things like interprofessional teamwork these days. And you might be getting a sense of that as we go along here. More problems occur when team members are not communicating clearly with each other. And when it comes to medical care, that's a pretty complex, sophisticated team of different specialists who don't always know what the other people are doing. And so the more they can interact, the better off you're going to be. And people do need support to get through hard times and to make good times. Now, support can be a lot of different things. It could be instrumental support, that could be doing something for someone, or it could be affective support, being there for someone. Interprofessional teamwork allows both of these things to happen. It's not without its costs, of course. Here we have some of the pros and cons of teamwork. Again, the advantages here are multiple perspectives and innovation are possible. You have more employees involved with decision making, which is good for both satisfaction and retention of those employees, and presumably problem solving. You also reduce costly errors, and it's good for that biopsychosocial care, which is that big picture perspective that most medical professionals are transitioning towards in the modern age. And this reduces both task and emotional burdens of the job on the individual team members by sharing those burdens. But there are costs to this as well. Some of the challenges of encouraging and facilitating more interprofessional teamwork would be that it is definitely more time consuming. If you've ever been in kind of a managerial position before, you might know what that feels like to be like, well, I could make someone else do this thing, I could teach them how to do it, or I could just do it myself. So teamwork can be more time consuming. It also runs the risk of groupthink, particularly in rushed or stressed situations. When people are under a lot of pressure to meet deadlines, for example, they're more prone to groupthink, which would be where the individuals of the group are prioritizing group cohesiveness over desirable outcomes. And so what can happen is you get a bad idea and everyone just goes along with it, right? You can take the time to look at modern politics if you want to see a lot of examples of groupthink going on, or just anything. This is a very common problem associated with identity politics of all kind. Now, you also have the typical diversity challenges with interprofessional teamwork in terms of you have several different specialists. They have diverse opinions and diverse specialties, if not diverse backgrounds themselves. And so more diversity in a work group does typically lead to more conflict, but it can also solve more problems. If we favor more of these pro-social behaviors that we've been talking about, you will reduce the conflict and promote the solutions to those problems. Now, finally, as we wrap up this discussion, I want to again remind us that at the system level of all of this, we've been talking a lot about kind of those micro and meso level factors of individual and organizational issues. But on the system level, we want to remember essentially that people are constrained by their systems, but they also can create those constraints. And so it's what we call a recursive relationship. So systems constrained. The people inside the system may not be aware of those constraints, or at least not viewing them as flexible as they can be. And while we do want to remember that systems resist radical change, small changes can have potentially large impacts due to the interdependence of those factors within the system. So small changes to efficiency in a medical system, for example, can pay huge dividends down the line. So this means that it helps us if we try to maintain a little bit of a big picture perspective on identifying problem areas in a system. This applies if you're a medical professional, and it also applies if you're just a random person going about your life in any organization or group. So again, the aspects of systems theory that are relevant here are recognizing the complexity of the system, that it is a recursive relationship, and it is also socially constructed. We build our constraints and are constrained by them in return. Organizational culture is another aspect of this, just remembering that every organization is going to have its own way of conceptualizing problems and dealing with them, and some things might just be done the same way they've been done for 80 years. That would be the organizational processes side of things. All of this resists intervention, but can be changed. You also, another constraint in the medical system would be the limited time that medical providers have with each patient. That is a major constraint, and it's a source of frustration for them as much as their patients. So we can maybe keep that in mind next time we see the doctor.